Yes, this is significant that 2 out of 4 papers selected for a plenary session focus on breast cancer. One is the combined analysis of 2 large studies, text and soft, investigating the role of aromatase inhibitors in premenopausal women. As you know, these compounds are used exclusively in postmenopausal women, but here was the question whether this particular exemestane, one of the aromatase inhibitors, in combination with LHRH analog, is better than the combination of the analog with tamoxifen, which is considered in some parts of the world as standard therapy, standard endocrine therapy in this population. And the answer is that indeed this combination provides some benefit in terms of disease-free survival compared with the standard therapy. This is not yet translated into overall survival benefit, but the difference is in the range of 4%, so it is notable, and perhaps we should consider it, if confirmed in long-term follow-up, as a new standard. And the other important study, again an adjuvant study, was the study comparing standard adjuvant therapy in HER2-positive breast cancer patients, that is chemotherapy plus trastuzumab, versus the same in addition of lapatinib, another HER2 inhibiting agent. And despite very promising data from the NeoAlto study, where these combinations were tested in neoadjuvant setting, where the CR rate was doubled, this study is negative. That is, there is a small benefit from adding lapatinib to trastuzumab at the expense of much higher toxicity, but most importantly, there is no significant benefit from this combination. Yes, that saves a lot of extra costs, and of course it keeps toxicity at the acceptable level. You have to remember that adjuvant therapy is, continued for 12 months, and of course it's very essential to keep good quality of life during this time. Indeed, a very interesting study showed that using LHRH analog during chemotherapy in premenopausal women increases the chance of fertility. It is not only translated into a higher rate of women keeping their premenopausal status, but also a higher rate of pregnancies, which is of course the most important final endpoint. This is still measuring genes, because these are genes related to immunology, immune genes, I would say. And indeed, the signature of 14 of these genes were shown to be highly predictive for trastuzumab benefit in the adjuvant setting. Namely, the NICE study, based on one of the large trastuzumab adjuvant studies, investigated the role of these genes in expression of these genes in primary tumor, and the study showed that around half of patients with particular signature has no benefit from trastuzumab therapy. So in fact, again, if confirmed in a validation study, even though they did several internal validations, if confirmed, probably a half of patients may be spared trastuzumab, or some other anti-HER2 therapy will be necessary to increase the benefit, because there is absolutely no benefit from trastuzumab alone. It also shows a very important role of immunologic factors in this type of therapy. This is this is meant to be anti-HER2 therapy, but probably there are also some other mechanisms, not only anti-HER2 action.